Hello, and welcome to this episode of In Discussion With from Medical Update Online. Today, I'm talking to Ashok Soni about how primary care pharmacy could help the NHS work more effectively. Could you start by introducing yourself?
My name is Ashok Soni. I'm president of the National Association of Primary Care. I'm a community pharmacist by background, but I'm also a non-executive director at Sussex ICS, known as NHS Sussex, and at Oxford University Hospitals in Oxford.
You've recently tweeted about some of the ways in which pharmacists could help the NHS in primary care work more effectively, and I'd like to explore some of these things in more detail. Could we start with letting pharmacists manage repeat prescribing? What is this and how would it work?
Obviously, pharmacists already do repeat dispensing, but one of the conversations I've had with many general practitioners from quite senior level down to the coalface is that actually the repeat prescription process is quite laborious from their point of view, and to a great extent involves continuity of medicines. And actually, from a pharmacy perspective, that's what we're experts at. Managing medicines and supporting medicines optimization. So the theory is that if we are able to monitor patients in the way that currently happens, and we could do that through point of care testing, which can be delivered close to home effectively through the pharmacy, or the patients bring their own results in, we would effectively maintain their medication as long as things hadn't changed. Obviously, we work within protocols, so if things did change in their health or there was a new condition or something we were unsure about, depending on what it was, you might refer them back to the doctor, because that would be appropriate if it was something which needed diagnostic response. But it may be that their medicines aren't working quite as well as they were, and actually the referral pathway there may well be to a more skilled pharmacist, somebody who has more knowledge around a therapeutic area and therefore is able to enhance the way that medicines are being used. And obviously the benefit of that from my perspective as a community pharmacist is that I would then have the opportunity that would provide me with learning as well, so that maybe in the future, if I came across something similar, I would be able to manage that patient's medicines differently. So I think there's very much more that we can do. And I think allowing us to manage that repeat prescribing would take a huge amount of workload off general practice and enable them to spend their time doing the things that they really are experts at doing.
So would all community pharmacists need to be prescribers for that to work?
No, you wouldn't, not initially, because you may be able to do this within protocols. So effectively what you'd almost do is be able to work within a range that was agreed between you and the prescribers within a neighbourhood, so that actually you were managing their patients according to protocols that were put together. Ideally, you would want the pharmacists to become prescribers, and over the course of the next 2 to 3 years, we're going to see that happen anyway. And actually, by 2026, all pharmacists coming out of university will be prescribers, and hopefully the vast majority of pharmacists that are already working out in communities will have had the opportunity to train as prescribers. So again, that enhances their abilities and their skills and enables them to do more in terms of that repeat prescribing management, and to be able to manage more of the patient's conditions and support their health and well-being.
And of course, it would be hugely useful from the patient point of view, getting a repeat prescription from a community pharmacy and not having to go back round the GP loop.
Yeah, no, exactly. And I think that's the thing in a way. Again, the same thing applies. That I get patients coming into me, and we do their repeat dispensing. So they come in and they go, right, I've come for my repeat prescription, fine. You arrange it, you prepare it, you dispense it, you supply it. And then after 6 months or a year, the prescription effectively expires and they have to go back to see their GP or their nurse. And they go, but nothing's changed. Nothing, I feel exactly the same. So why am I going to see the GP? And then they go because they say, well, that's because that's what you have to do. So they go, and that takes time because again, there's capacity availability within general practice. And then they come back and say, yeah, so I saw the doctor stroke nurse and they said to me, is everything all right? And I said, yes. And they went, oh, okay, I'll just renew your prescription. So again, that takes away that piece of workload. And as I say, if things are changing, there's no reason why, with the appropriate levels of IT and with various other things, you wouldn't be able to manage that more effectively and be able to speak to that doctor or nurse to say, things have changed and I need more help and this patient needs more help. So actually they go when they need to be seen rather than just because the system says it's time.
And another point, how would community pharmacists be paid for this?
There are different ways of doing it. You could do it in the same way as we do today, which is activity-based. So every time you see the patient, you'd carry out the review, and then depending on what your decision was, you'd be paid for the consultation effectively each time. The other opportunity is, of course, what you could do is if those patients were coming to the same pharmacy, what you would expect if you were supporting their repeat prescribing, then theoretically there's no reason why they wouldn't be either registered or pseudo-registered with the pharmacy, and therefore you'd pay for the patient's care for a period of time. So you might turn around and say, for you to support and manage their care for the next year, we'll pay you X amount. And that will include all of your consultations, the time you take, however it would work. And that there are different ways to do it. And I think, in a way, that's not for me to worry about. That's for those that are paying for it and those that are there to negotiate on my behalf to do that. My purpose is to come up with the proposal about what we can do. It's for others then to work out in a way what's the best way to pay for it. And there are different ways to make that work, and as I say, and I think we can, and there's no reason why you can't find the resource to do that. Because if I'm releasing capacity from general practice, and that means that maybe some patients aren't going into hospitals that currently are because they're better managed by the GP as well as by us, that's going to save money at some point in the system, and therefore that money is just being redistributed.